Welcome to Conversations in Interventional Cardiology. My name is Andy Goldsweig. I'm the Medical Director for Structural Heart Disease, the University of Nebraska Medical Center. I'm Associate Editor of JSCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent JSCAI and our Editor-in-Chief, Dr. Alexandra Lansky, today. You can find us online at jscai.org and follow us on Twitter at myjscai, at MYJSCAI. JSCAI is the home of all official SCAI documents and publications. We're here today to discuss a very important recent publication in JSCAI entitled Early Surgical Aortic Valve Replacement versus Watchful Waiting for Patients with Asymptomatic Severe Aortic Stenosis, a meta-analysis of randomized controlled trials. We have an esteemed panel of internationally renowned experts. First, Dr. Yousif Ahmad is the first author of the paper, an interventional cardiologist at Yale University, with specific expertise in both valvular heart disease and coronary chronic total occlusions. We also have Dr. Philippe Genereux, co-director of the Structural Heart Program at Morristown Medical Center in Morristown, New Jersey, and a leader in the field of structural heart disease for more than a decade. Welcome to both of you. Thank you so much for joining. Let me start by directing a question to Dr. Ahmad. Our listeners probably know that current multi-society guidelines recommend aortic valve replacement in patients specifically with severe symptomatic aortic stenosis. Now, in this paper, you and your colleagues provide evidence to support surgical aortic valve replacement in patients with severe asymptomatic aortic stenosis. Could I ask you to summarize your group's findings for our listeners?
Great. So, that was exactly what prompted us to undertake the study. The guidelines recommend aortic valve replacement, either transcatheter or surgical, for patients with severe symptomatic aortic stenosis. And, it's kind of bedded into us all, through our medical training, that the management of aortic stenosis is dependent on the patient's symptomatic status. That's really been the way we've all been trained to manage these patients. And that's, based in large part on this seminal figure that everyone is familiar with from a paper from Brownwald in the 60s, which is a post-mortem study. And, that has to be balanced against an emerging evidence base from other observational studies that indicate that patients with severe aortic stenosis have significantly elevated risk of sudden cardiac death. And in fact, even in less severe forms of aortic stenosis, the risk of death is increased. The guidelines, as you mentioned, indicate that in patients with who are asymptomatic, the only class 1 indication in both American and European guidelines in patients with reduced ejection fraction. There are a handful of class 2A recommendations to do with exercise testing, very severe aortic stenosis, or biomarkers such as elevated BNP. And the European guidelines, in large part agree with the American guidelines. But there is now new randomized trial data regarding the management of asymptomatic patients with severe aortic stenosis, and particularly with early surgical aortic valve replacement. There have now been published 2 randomized trials which compare early surgical aortic valve replacement with a strategy of watchful waiting for patients with asymptomatic severe aortic stenosis. So we undertook a random effects meta-analysis of both of these randomized trials. We pre-specified our primary endpoint to be all-cause mortality. We also looked at cardiovascular mortality, heart failure, hospitalization in the composite. And we also used published Kaplan-Meier curves to reconstruct individual patient data to get a pooled, synthesized Kaplan-Meier plot so we can get an idea of the temporality of events. This is, our sort of main findings for those 2 endpoints. In the top panel of the forest plot is the all-cause mortality, and you can see the hazard ratio is 0.45. You can also see the heterogeneity is 0. That means the results of these trials are agreeing with each other. You can see the point estimates are close together, and the confidence intervals nearly, completely overlap between the 2 of them. And if you look at rehospitalization, again, we have a highly statistically significant benefit and a large order of magnitude of benefit in favor of the early surgical group. And again, heterogeneity was low, indicating that these 2 trials seem to agree with each other. Synthesized Kaplan-Meier plot shows divergence of the curves fairly early, but, the curves continue to diverge later on. And the hazard ratio is very much in agreement with that of the conventional meta-analysis. Our conclusion from our study was therefore that early surgical aortic valve replacement reduces all-cause mortality as compared to a strategy of watchful waiting in patients who are asymptomatic and had severe aortic stenosis and who met eligibility for entry into these two randomized trials. There are, some important considerations when we are looking at trying to apply these results to our patients. The first one is these results really only apply to patients at low surgical risk. And I do think low surgical risk is very important when you're proposing an intervention for a patient who's asymptomatic. So the average age, in recovery was 64.2, in Avatar was 67, and the difference metrics of surgical risk were very low. And this is reflected in the operative mortality, which was very close to zero in both trials, 0% in recovery and 1.4% operative mortality. And it's important that we have to acknowledge that these results don't apply to transcatheter aortic valve replacement, but it is inherently an appealing strategy to offer a less invasive approach for patients without symptoms. It's hard to put a patient who's completely asymptomatic through a procedure which is very invasive with potentially higher morbidity and mortality. But patients who may be offered a less invasive approach, this could be, a good strategy, but it's one that needs studying. There are limitations. We have to acknowledge that the two trials don't have identical or even completely similar entry criteria. The Avatar trial mandated exercise testing. And if you look at recovery, it's possible that they included a subset of patients who weren't truly asymptomatic because exercise testing in recovery was only performed according to clinical judgment. And we saw from guidelines early on that exercise testing already has an indication for intervention for severe asymptomatic aortic stenosis. Patients in recovery also had pretty critical aortic stenosis, and you could argue they almost already meet guideline recommended criteria for surgical aortic valve replacement or some form of aortic valve intervention. And we have to, acknowledge that number of patients in both of these trials is very small. It's about 300 pooled patients across the two trials, and that means the number of events is small. We're looking at a handful of events. I think a pooled number of deaths of 15 in the surgical arm and 30 in the watchful waiting arm. And there was also, potentially an impact of COVID. If you look at Avatar in particular, there was an imbalance in the number of patients who died from COVID-19 between the two arms. Now that could either be, a chance finding in terms of COVID confounding the results, or it could also speak to the difficulty in adjudicating causes of death. But in that trial, there wasn't a difference in cardiovascular mortality. And we would assume that surgical aortic valve replacement, if it's going to reduce all-cause mortality, would be by reducing cardiovascular mortality. And I think it's, worth acknowledging that there are going to be several, hopefully, trials looking at transcatheter approaches for these patients. And the number of patients in those trials is really going to dwarf the number of patients that have been recruited in the published surgical trials today. This isn't an exhaustive list. This is just a handful. And, we have Philippe with us who can tell us about some of them, and I think in a lot of detail. But the landscape of evidence for patients with asymptomatic severe aortic stenosis or other clinical syndromes such as moderate aortic stenosis and heart failure, that's going to change a lot in the coming years as we get, the results of these randomized trials in the coming years. So I will stop there and thank you very much.
Wonderful. Thank you very much. That's a fantastic summary. And you and your colleagues really did a great job synthesizing the evidence from recovery and Avatar and providing a 302 patient strong body of evidence to support early intervention for asymptomatic aortic stenosis with surgical aortic valve replacement. Turning to you, Dr. Genereux. Dr. Ahmad's work focused, as he said, specifically on surgical aortic valve replacement and may not apply directly to the elephant in the room, transcatheter aortic valve replacement. We also know that transcatheter aortic valve replacement has eclipsed surgery as the predominant AVR modality. So the question for you then, can these findings be extrapolated, be applied to TAVR? What additional evidence do you think is necessary? What do we as a cardiovascular community need to do to find out whether this should influence our utilization of TAVR?
Well, first of all, I want to congratulate Dr. Ahmad. It was a very nicely written paper. Too small study, but still a hot topic. And I believe that even if we're very enthusiastic about intervening in early in a severe asymptomatic patient, I think those two trials were very specific. Dr. Ahmad mentioned it. Recovery actually was extreme, was very, very severe, was critical AS. Actually, the peak velocity was 5.0. The mean age of patient was 65. There's no stress test. Only 10% of patients had stress tests. So it's it's really validate for me that if you have critical aortic stenosis with no symptom, it's okay to have surgical AVR. But it was very low risk patients, 65 years old, and mainly everybody get a mechanical valve, and half of them were bicuspid. So for me, it's just legitimize the early intervention with surgery in young patient, like the guidelines say actually. Apply surgical AVR in asymptomatic patient, apply only for low risk patient with surgery. Avatar was a little bit more looking at patient maybe, possibly but candidate for TAVR, but still young patient, low risk, a lot of mechanical valves. So I think that's give us a justification and some base for early TAVR or early intervention with TAVR. That being said, we still don't know, and the guideline does not support that. And it's maybe a gap in the guideline, to be quite honest. If you have an 85 years old patient asymptomatic, obviously, we may believe the guideline should apply to that, but it's not out yet. So I would say we finished early TAVR about a year ago. Very excited to have more than 900 patients that will potentially answer this question. For sure, we're going to learn a lot. There's probably very heterogeneous population in there. There's severe and there's very severe, and but I think that we're going to learn a lot. So we have to wait for early TAVR. I think Evolve, which is the other one, Evolve TAVR and surgery, will also give us a different perspective using maybe biomarker, MRI, other modality to characterize, I would say, cardiac damage. So I think the jury is still out on this question for TAVR, but we're going to have very strong evidence to support, or I would say to modify the management of AS, whatever it is, early TAVR or early follow-up, or different perspective. So I think we have to wait the result of those trials.
Yeah, those are certainly critically important trials. They're also very hard to enroll. Congratulations, certainly, on completing enrollment in early TAVR. I know that's in follow-up now. Early TAVR and Evolved have really done great with enrollment. TAVR Unload and Progress, especially TAVR Unload, really struggled to enroll patients, not only because of tight entry criteria, but because of the challenge that all these trials face, randomizing patients who are asymptomatic to having procedures or not having procedures. The interaction in the clinic. Sir or ma'am, I have a great procedure I think would really benefit you. Would you be willing to be randomized 50-50 to maybe have that procedure? That's a hard conversation. It's a very hard sell.
Yeah, I will mention just one point. So if Progress and TAVR Unload or a trial targeting moderate AS patient, and specifically TAVR Unload, focus on moderate AS with LV dysfunction. So actually, there are very, very severely symptomatic patients, very sick. Progress actually take a more holistic approach, where it's everybody with moderate AS, with normal EF, symptoms or not, but with sign of cardiac damage, with diastatic dysfunction, symptom increase in NT-proBNP, et cetera. So those trials are moderate AS. So the problem with TAVR Unload, unfortunately, is it's very niche population. This is a patient that are very sick. So you have patients with moderate AS and also very severely depressed LV. And they're, to be quite honest, it's kind of hard to find. And there's probably people that believe there's already a benefit there. They were already treating those patients. So that's what make difficult TAVR Unload. I would say Progress is ongoing, and we have a very quick enrollment because there's a lot of moderate AS with normal EF that have symptoms, that have 1.1 valve area, for example, 32 mean gradient, AFib, and they're symptomatic. So this is the question of the cutoff of AVA less than 1, mean grade more than 40. Nobody's made equal. Nobody reacts the same to the pressure overload. So should we change a paradigm of 1 to something else? Should we change a paradigm of 40 mean gradient to something else with elevated NT-proBNP, for example, or decreased strain or diastolic dysfunction. So those two trials, I would say TAVR Unload and Progress, or I would say much more progressive because they focus on pushing the boundary on moderate AS patient, which I think are a game changer in by themselves. Yeah.
Mm-hmm. I think you raise a great point that a challenge in the moderate AS trials is that while you may see a patient and randomize the patient, the guy down the road sees the patient, traces the continuous wave Doppler a little deeper than you did, and declares the patient has severe aortic stenosis and offers the therapy. Anecdotally, we've been attempting to enroll patients in TAVR Unload for 3 years and so far enrolled 5 patients. It's certainly a difficult one. But on that note then, a question really directed at both of you. Dr. Ahmad's study is a meta-analysis of randomized control trials, which certainly are the gold standard, but they are expensive, they're time-consuming, they're difficult to enroll. And so we are seeing more and more studies of other sorts, especially meta-analyses like this, to accumulate more data from smaller studies and observational studies. So the methodology question for both of you then is, how should cardiologists and cardiac surgeons interpret data from meta-analyses and from observational studies, which were specifically excluded from the present study? Are data robust enough from these types of studies to influence guidelines, specifically in this case, to recommend SAVR for asymptomatic severe AS?
Yeah, I can start with that one. I think it's a very important point. The randomized trials are very, very expensive. I think meta-analysis is, becomes somewhat maligned because, it can be, performed readily, and it really depends on the methodology you apply. And so it depends on the trials that you include or the studies you include. And if you perform a meta-analysis of studies that aren't appropriate to pull together, and let's say that aren't appropriate to answer the question at hand on their own, then you're never going to get a meaningful answer from them. But, all cardiovascular trials these days have composite endpoints. And we do that because we have to reduce the sample size. We have to have a realistic sample size to complete the trial with a realistic cost. And that means that each individual trial is underpowered for clinically important but low frequency events such as mortality. And so if you want to discern a difference, a significant difference in an event, let's say like mortality, between competing therapies, often the only way you're going to be able to discern that is with meta-analytic methodology. But it's critically important that the trials that you pull together are appropriate to pull together. And I think we often forget that, primary angioplasty only demonstrated a mortality benefit over thrombolysis through meta-analysis of trials. So it can be a very, very important tool to discern differences in low frequency events, but it has to be applied judiciously and appropriately.
So I will agree with Dr. Ahmad, and I think even if you only pull 2 studies with 302 patients, at least it's 2 randomized trials. So we did the same work when we designed early TAVR. So we did a review of literature, and we pull out the data, which were all retrospective. We have 2,400 patients, I believe, we published in JACC, and obviously you have an effect which is very significant, that show that patient that underwent, and this is all retrospective, underwent surgical IVR did way better than patient that did not. The problem with that, obviously, you just accumulate all the bias of the trial that, the patient that you do a surgical IVR at 82 years old, they're in good shape. And the patient that you don't do at 82 years old is because they're dying and you abandon them. It's not clinical surveillance. It's just you decide not to treat because they're so sick. And then you can adjust for everything you want. But the fact that you decide not to treat them, it's not randomized. So there's a long list of trial that fail despite very, very significant positive meta-analysis. So I think that's the reason why we need randomized trial to really have a definitive answer. Otherwise, if you pull all the retrospective study, and we did this in early TAVR, to at least have a simple a side effect, how do you power your randomized trial? Most of the time it's with meta-analysis or guesstimate of what you see in clinic. So I will believe, for me, meta-analysis is a good summary of the data available, but you need to really analyze them cautiously.
Well, thank you so much, Dr. Ahmad, Dr. Genereux. We're absolutely thrilled to speak with you, and we're thrilled to include this important paper in the 4th issue of JSCAI, and to share this discussion with this incredible panel on the JSCAI website. Please follow JSCAI, submit your own work to JSCAI. JSCAI is the official journal of SCAI, and online at sky.org/JSCAI and at myJSCAI on Twitter. Thank you so much.